Welcome to our lecture series on clinical pharmacy practice. And also, thank you, Jay. Thank you, Mom Nelly, for this opportunity from UV Clinical Pharmacy Department for this opportunity to discuss to you about clinical pharmacy practice and education in the Philippines. So I am Dr. Erwin Martinez Falier, visiting professor in Bournemouth University, United Kingdom, and also a fellow of the Royal Institute of Pharmacists in Singapore. So I'm going to go on with the slides as per discussed, and I'm also going to give you some objectives of this presentation later on. So I'm going to introduce myself first. I'm Dr. Erwin, and usually this is my current researches and books that I have published with. Mostly of my research interests are into pharmacovigilance, pharmacy education, ASEAN competency skills on pharmacy education, migration researches, some clinical pharmacy research on pneumonia and hypertension, diabetes. It's not only in the Philippines but also in the international arena. I have also published several books, including of which is my book chapter in the Encyclopedia of Pharmacy Practice and Clinical Pharmacy and the pharmacy practice in India. So these are my impact to the profession, mostly established with different organizations in the country and in the ASEAN regions on global health pharmacy. And I've been a contributor then into different medias like Palawan Daily newspapers and also Davao Today and also Swipe RX, and contributing also with memorandum of understanding and agreement with Philippine universities with other international universities and colleges. These are my awards. I have been awarded as a Bagong Bayani awardee and also with different fellowship from the Royal Institute of Pharmacy in Singapore. Mostly of my teachings in outside the country are more into clinical pharmacy and pharmacy practice. I've been teaching also masters in clinical pharmacy and also teaching several subjects, in the Philippines and also in abroad. So my topic is all about clinical pharmacy practice and education in the Philippine setting. So let's try to define first what is all about clinical pharmacy. So as we all know, clinical pharmacy has been defined for several decades already, and it actually emphasized to us that it is a health science discipline in which pharmacists provide a patient care that optimize medication therapy and promote wellness, health, and disease prevention. And usually, this is an area wherein it is concerned with the science and practice of a rational medication use. Now, if you're not involving with patient, are you practicing clinical pharmacy then? No, because as we all know, that clinical pharmacy is working directly with patients and also with other healthcare providers. So there are more interactions, there are more communications with the different patients and also with healthcare team. So that is all about clinical pharmacy. It's not only teaching it, it's not only doing it your own, but then it is actually going beyond of it, talking with patient and also healthcare provider. This is according to the American Colleges of Clinical Pharmacy. Now, according to FIP, Federación International Farmacéutico, it mentioned here that it gives the significance of pharmacy education and diverse practice of contemporary pharmacists and pharmacy support personnel, that there is a great need for pharmacy education to attain what we call as greater visibility on the global human resources for health practitioner or health agenda then. So this is the perspective of the FIP that pharmacists are not only at the counter or pharmacists are not only behind the scene, but then we should be visible then to the public. And that is where clinical pharmacy is coming from. So going to a visible for our patients. So not actually not actually not only that it is imperative that clinical pharmacy should be visible then. And according to FIP, that the development should be holistic and comprehensive, no? Within the pharmacy education and the workforce that strengthen the health agenda of the nation. So it's not merely the creation of clinical pharmacy for the sake of clinical pharmacy. It's not for the sake of education or for the fame and glory of the profession, but it is actually for the betterment of the Filipino people. No? So that's the main emphasis of the FIP. Now, looking at the transition of pharmacy practice, we all go through the history of pharmacy that from a manufacturing pharmacist then compounding pharmacies from 1800s going beyond to the hospital and community pharmacies as a dispenser then and the promulgation advent then of clinical pharmacy in the late 1900s and going to the concept of Hepler and Strand of pharmaceutical care. Now we are actually in the advent of what we call as specialization services that address more on the health demands of our patients. So it's not only that when you say clinical pharmacist, what would be your specialty then? No, as a clinical pharmacist, are you expert then on a particular area that address on what health demand? Is it in cardio demand? Is it in nephro? No, is it so it's specialized on a particular area of discipline then. So that is what we are into the transition of our pharmacy practice. Now, moving on in the Philippine setting, I know that you know this person, Dr. Chopin Po. This is recognized as a Dean of Hospital Pharmacies by the Philippine Society of Hospital Pharmacists. She was also the president of the Philippine Society of Hospital Pharmacists in the late 1980s. And she was actually known as the advocate of clinical pharmacy that incorporate training on necessary skills in drug therapy management. So she opened the door for clinical pharmacy in the different hospitals in the Philippines. I was shocked that when I Google with her name, there are few literatures only looking at Dr. Shopinko. I think we need to really show to the international arena how clinical pharmacy actually started then in the Philippines. And I actually written there in the Encyclopedia of Clinical Pharmacy on some of the good deeds of Dr. Shopinko no, as the advocate of clinical pharmacy. Now, to what we are now, then there are a lot of very blooming, booming, particular hospitals in the Philippines. To name a few, we have St. Luke's Medical Center, which has a bed capacity of 610. We have the Medical City, which has more than a 800 bed capacity. Makati Medical Center, which has almost 500 bed capacities. And most of them they have different services so like Davao Doctors Hospital. We have also Philippine General Hospital, no, the Medical City and Cardinal Santos Medical Center, and also included with this like Southern Philippines Medical Center in Davao City. They have different services, you know, from the main pharmacy, satellite pharmacies. We have also extemporaneous compounding services in the central pharmacy, oncology pharmacy services. We have added to that services, we have clinical pharmacy service. those clinical services that I'm going to mention now, like for example, drug therapy management, medication reconciliation, we have medication counseling, we have drug information services. These are the things that have been offered by these big hospitals in the country. No? So, looking with that, what are these services then, and how this actually have the impact to the society as a clinical pharmacist. So, looking with that, the main objective of this PowerPoint slide, so this presentation that we have, is to illustrate on the clinical pharmacy areas and how this is actually relevant then for a pharmacist. And I'm sure that you miss a lot because you don't have your internship in your clinical pharmacy program. But this will be a supplementation for you when you go exactly to your into your hospital setting or to your clinical pharmacy setting. You will really appreciate what is going on into the clinical pharmacy services. Another objective would be to identify in terms of the clinical pharmacy services that they have been providing not to the patient, and to identify what needs to be improved for these services. No, there's no perfect services that we have. Everything is actually improved. And how can this actually improve to the country then? Now, the pharmacy services that I mention is example with the unit dose dispensing system, centralized review process, actual patient chart rounds, multidisciplinary team rounds, code and rapid response team, clinical pharmacists, and more. The main coverage of these services, it may be 8 hours, per shift. So there will be more than 10, or some of the hospitals, they have 200 pharmacists in one hospital only, including, of course, with the hospital pharmacists that they have. Now, in the unit dose dispensing system, is actually wrapping a single pack with this in every individualized doses that we have, rather than giving the total dose to our patient. No? So this is a pharmacy coordinated method of dispensing. The pharmacist, the clinical pharmacist, is the one who actually wrap this and put it into a single pack, and they are being controlled by the clinical pharmacist then in an organized healthcare setting. Now, in the unit dose dispensing system, there are very distinctive elements, no, that are basic to all unit dose, because some of the hospitals actually are uncomparable. When you have clinical pharmacy services, you actually adopted this what you call as unit dose dispensing system. No? So unlike with others, like they have only hospital pharmacy services, they don't have this unit dose dispensing system. It may be, shall we say, expensive for some, but then some of them, they may have this automatic unit dose dispensing systems. Some of them, they may have this manual dispensing systems that we have. No? So in the unit dose dispensing system, the medications are contained in a single unit packages, and they are dispensed in a ready to administer form as possible. And most medications, not more than 24 hours supply of doses is delivered to or available at the patient care at any time. So it the main advantage then of a unit dose suspension system, it actually reduces in terms of the not only with the cost, but also reduces in terms of medication error then. Now, in terms of the cost, it is very cost effective, no, for the patient. Now, this is the initial step then for clinical pharmacists to implement, the practice of clinical pharmacy in the particular hospital. So looking at, the start of the patient drug profile, ensuring compliance with drug therapy, coordination with a physician and other healthcare professionals. So these are the main steps to adopt clinical pharmacy program. This is a start for the clinical pharmacy program to be adopted into. There are a lot of struggles in a particular hospital to adapt with this, no? Because the interpretation in our mind when we say clinical pharmacy is too technical, looking at being as a police, no? It's not actually looking at being as a police then because it's kind of threatening for other healthcare provider when you look at being policed, no? But then how can we clinical pharmacists then impact to the patient then how do interaction then these are just a tool, no? In terms of drug profile coordination with physician ensuring compliance, but how can we assure compliance of drug therapy, how can we assure the maintenance of drug profile, how can we coordinate them, what's the central of it, the central of what we're doing is actually our patient then. Next one would be in terms of, these are the example of the medication profile. You cannot actually see, this is quite very little, but then it actually looks at what are the current medications. It's not only the the synthetic medications that we have, but also in terms of the herbal supplements that patient is actually taken. When is it being taken? And when they actually stop, who actually gave it the time, no? The duration, the frequency, no? Given to the particular patient. So you can see here in an example wherein pharmacists actually trying to prepare the unit dose and putting into the basket no, in on each patient look patient looking at preparing it every single dose for the patient. So you can see the pharmacist trying to document also in the unit dose dispensing system. And you can see also in terms of the baskets. So these are the baskets of the patient per room, okay, and also per bed. And also, what is he doing there? No, in the computer, is he reading it or is he actually sleeping? So he's not actually sleeping. He's actually looking at the computer. This is what we call as the centralized review process. What is this all about? Centralized review process. You can see that in the monitor that most of the cases of the patient is there in the centralized program. No? So the pharmacist has an access to what are the cases, like for example, case A. Now with this particular disease, no? So what are the medications given to this particular patient in case number one? No? So that one. So it actually looks at different patients. Now, what are the limitations then? So there will be lack of face-to-face interaction. So if you're assigned on a central, usually if you're a beginner, you for as a clinical pharmacist, you'll be assigned mostly in the central review process, because you are gonna be familiar what is going on into the system and what are the drugs that are usually being given. So you identify if there are drug interaction, drug food interactions, and of course the prescribed medication by the prescriber or by the doctor, and of course there will be active medication reconciliation. Maybe there's a lack of it because you are not the one who actually have the face to face with your patient. What have they taken? You haven't coordinated with the doctor because you are assigned in a central review system, no? And you review process. And of course, patient discharge counseling. So you're not going to be, there will be limitation because you'll be assigned in a central process. But if you're given a chance as a clinical pharmacist going rounds, you'll be also dealing with the discharge medication. So you'll be counseling patient on the discharge medication. Now, this is some of the pictures by the Medical City Pharmacy Services. What are they doing? what are the tools or the data that they are actually looking at. Are they looking at mistakes? Are they looking at what are the errors by the doctors? Or what are they doing? Of course, we are not looking at the errors of the doctor. It's a wrong perception as a clinical pharmacist, but we coordinate with the doctors and other healthcare providers on some drug related problem. So that's the difference between us and of course other healthcare provider because we look at drug related problems. Take note with that, drug related problems. Now, on the medication reconciliation as part of the clinical pharmacy services, they actually been, if that to be a newly admitted patient, then the clinical pharmacist will actually review for 24 hours, including the medications prior to admission. If that to be an acute critical care unit, that will be 4 to 6 hours after admission to check if there are any drug related problems that they have. And of course, for those who have maintaining their medication. So it's basically reviewing it by the clinical pharmacist within 24 hours, or if that would be in critical care, that would be 4 to 6 hours. So that would be depending upon the different assignments you will have. Looking at also some of the examples here, so you cannot actually read it, it's a handwriting of a doctor. So that some of the examples would be informed clinical pharmacists regarding medication. So it's actually been recognized by the doctor how what is the impact then to the patient and to the healthcare team. We are helping and coordinating with the physician, with the doctors in terms of their medication, to avoid medication errors and more cost effective for our patient. Now, looking at medication review, it's like when the doctor is actually given with a certain medication, it may be because in a clinic or in the community pharmacy or in the hospital setting, there are a lot of patients. In one day, they may have 100, they may have 50 to 100 patients in a day. No? So basically, who actually looks at drug-related problem? It is the clinical pharmacist who will advise, who will tell to the prescriber or what are some of the drug related problems if possible to avoid certain side effect of this particular patient, so we help them, no? So we try to look, we interview the patient or what are the current medications that they have, if they have also herbal supplements, if they have contraceptives, if they have implants, if they have surgeries, what are the medical histories that they have, the past medical history, the past medications that they have, all those things must be must actually be collected by the clinical pharmacist, and appropriate review must be set, if there are drug related problems then that's happening. Another is therapeutic drug monitoring and adverse effects. So this TDM, there are limited hospitals that are adopting this TDM, wherein TDM, therapeutic drug monitoring, is that a certain clinical pharmacies or a medical technologies actually get a certain blood sample to the patient, and then after which is once it gets with the blood sample, it is analyzed by the medical technologists or the clinical pharmacists. And then after they analyze it, they look at if it is within the therapeutic range, of a certain blood plasma level. So, like for example, if that would be for vancomycin, phenytoin, carbamazepine, warfarin, which are very low therapeutic index, so very narrow therapeutic index of that, it should be monitored by a clinical pharmacist. So that is what we call as therapeutic drug monitoring. Then, so there are some hospitals that are adopting with this therapeutic drug monitoring, to actually lessen in terms of adverse events or adverse effects to the patient because they have a very low therapeutic index that they have. So it's very exciting to have because you need to have a lot of computations, you need to have a lot of analysis if it is really on the on this on this therapeutic range, based on your calculation. Anyway, don't be afraid of it because everything is already online. You can actually use online calculations then not to solve, but you need to have the basic formulas or basic equation for this TDM equations for every particular drugs. Uh, and of course, you need to monitor the patient with this. That's the work of a clinical pharmacist then. Another thing is for the review. Of course, these are our monitoring tools then. What we're looking at is actually the data in terms of their demographic. Example, the name, the age, the gender, the sex. If the patient have an allergy, the age, the height that will identify in terms of their BMI, the list of medications, if the medication profiles of the patient that should be identified by the clinical pharmacist then so you have a form of it in terms of the medication profile, and that is actually based on the RA10918, which also looks at the patient medication profile. That will be discussed later on. And also laboratory test results if the patient have elevated sodium, magnesium, no, and ions, no, and of course increase of creatinine clearance, no, and of course what kind of procedure that they have, if that to be having endoscopy, and of course other procedures, and the equipment that is being used by the patient and hook up into the particular patient then. No? So it needs to be on data recorded, those technicalities then, into your chart. No? So that would be your tool then to analyze. So that's the main importance. You need to gather data because you want to analyze then or what would be your pharmaceutical care for your patient, your interventions, and what would be the outcome then for your patient. Now, some of the pharmacists also looking at after monitoring, they're gonna be given with a discharge medication. So you'll be the one who will counsel the patient in terms of this discharge medication. So you need to be alert that the patient is already going to be discharged because sometimes the nurses will not actually prompt you. You need to be alert as a clinical pharmacist if the patient is going to be discharged on that particular day. So proper monitoring should be alert in the clinical pharmacist. So this is some of the services.
Untuk lagi ni anhin ako under no?
This review is actually looking at how appropriate is then for the for the particular drug, dose, the rate of administration, the frequency, the route of administration then, and if there are any duplications, sometimes the doctor A actually wants to administer with this antibiotic, then another doctor actually gave another empirical antibiotic then. So it will be dual therapeutic duplications and like for example antihypertensive drug A and another antihypertensive drug that will cause hypotension later on. No? And of course, potential allergy, sensitivity that will cause anaphylactic shocks, potential interaction if there are any drug interactions, drug food interactions that need to be avoided by the patient, drug laboratory, drug disease, and of course those drugs which have high alert medications like for example anticoagulants, heparin protocols, and of course some informations that need to be gathered, they need to be collected then like patient's weight, and of course some physical chemical compatibilities, an issue of delivery of parental nutrition and other contraindications. So you need to look at if this is inappropriate or it needs to be stopped already, like antibiotic for 7 days. So if there's more than 7 days, then so it should be stopped, right? So there are some medications that need to be stopped by the order. So you need to be alert with this kind of appropriate review. Now, there are multidisciplinary team rounds that we have. So we have pharmacists, need to accompany also with the doctors. Some of the hospitals, they will not actually start where their medical rounds without the pharmacist. So it really recognizes then the presence of the pharmacist. But depends on how you assert, how you collaborate with the doctors then. So the thickness of the face should be there, no? For dealing with healthcare providers, dealing with physicians, specialists, no? There are what will be the advantage of this? Of course, there are experts. They talk about during the rounds. They talk about the condition of the patient. They actually review from the start, no, what actually looks into the disease, the medications, the regimen, no, everything. So it's been discussed during the multidisciplinary rounds. No? Even like example, there are some patients which have non-compliance of the medication, so you need to really have this intervention during the time, when you have this medical round. So you need to take note what would be some of the recommendations by the healthcare team. And and another thing is some of the hospitals, clinical pharmacy services, they have this code and rapid response team. So some of them, they're preparing extemporaneously, compounding. They have some clinical pharmacists that administer. They preparing in terms of their infusion pumps. They do also chest compressions. So have you tried to have chest compression when you are a pharmacist in the hospital? I've experienced that one. No? So you need to be well-rounded in terms as a first aider. No? So you need to do also CPR. No? Cardiopulmonary resuscitations also when you are in the hospital settings also. So it's not only pharmacists that you're dealing with, but you need to be multitask also. No? Another thing is so what is then in terms of our clinical pharmacy education? In reality, that most of the experienced one are a lot compared to those uh, those who are enrolled in a clinical pharmacy as of the moment. No? So we will wait until that most of our heads and of course most of our experience will be replaced also by those which are enrolled already with a clinical pharmacy. No? That's usually in the Philippine setting that some are only been trained, not enrolled with a clinical pharmacy program. No? And uh, that is in the Philippine setting. Now, this is actually mandated according to the CHED Memorandum Number 3, Series of 2006, where in the main purpose of this CHED Memorandum is for global competitiveness of clinical pharmacies and pharmacies services to the country. No? So I hope and I pray that this would be an eye opener for us that we need to help our country first before other country. No? So amidst the global competitiveness of us, that we need actually to serve our country. No? For improving our country in terms of clinical pharmacy. Then now looking at our pharmacy education, because when you graduate pharmacy for 4 years in a certain university, you need to add up 1 year to become a clinical pharmacist. And if you want to have your PharmD program, you need to have at least 5 to 6 years then to become a PharmD graduate then in the Philippines. Yeah? So it's quite different from other countries. So like in other countries, they have 4 year program plus 2 years of experience in the hospital to become a clinical pharmacist. Yeah? So that's the main difference of our curriculum that manifests in terms of our clinical pharmacy practice in the Philippine setting. With the new pharmacy law, it encourages us dynamically in terms of pharmacy counseling to our patient and also improving our medication history profiling and of course dealing with more with patient rather than a product oriented pharmacy. So this RA 10918 actually encourages us to deal more with our clients or with our patient. And these are some of the example of the medical city. You can see that they are very dynamic, adapting with the clinical pharmacy, and also not only the medical city but also other hospitals in the country. Even though with the start with the whole process, but then practice makes perfect, in dealing with our patient. As long as we are sincere in terms of dealing with our patient and to have an impact to our clients or to our patients. So clinical pharmacy is not only adaptable in the hospital setting; it can be also adaptable in the community settings, not only in the hospital. No? So if you talk with with your patient, when you actually talk about adherence program, then so it actually looks into the clinical pharmacy, because as what we mentioned, it needs to have patient interaction with patient and changing in terms of their drug related problems, then okay, addressing with the drug related problems. So there are clinical presentations, no, so they really open it with the students also. Now, there are a lot of, based on our research, then, there are a lot of needed competency for pharmacy clinical graduates then. No? So they need to have a basic components of all those things: communication with doctors, presentation skills, written documentation. You need to be well versed in research, participate in rounds, participate in presentations, actual charting, compounding, literature search. You need to have this all as a component of a clinical pharmacy, clinical pharmacist. Yeah? And most of these clinical competencies are being assessed. Now, we have actually a research that was published in International Journal of Indian Journal then, that leadership skills and communication skills, assessment, drug literatures, health promotions, physical assessment, and other critical thinking skills that we have should be incorporated in our skills as a pharmacy student, as a clinical pharmacy student. So all those things must be incorporated with you as a clinical pharmacist before you go to a certain industry or before you practice clinical pharmacy. So that's the different skills. Now, how can you actually differentiate it when you don't have a comparative of the practice in the Philippines? If you would say that as part of our learning objective, that to identify what needs to be improved if we don't have actually a comparison, then the comparison that I'm going to tell you is the comparison of clinical pharmacy practice in Malaysia. As what I have mentioned, that I've been practicing also pharmacy, teaching pharmacy in uh, in Malaysia for almost 8 years, and I've been a preceptor there in a clinical pharmacy program and also teaching masters in clinical pharmacy, in Malaysia. Then what they actually doing, they also adopt what we call as unit dose or unit of use system, wherein the stool system allows the distribution of the drug to the wards to be done in an efficient manner and a cost effective manner that also minimize medication errors and wastage. And that is what they are also practicing similar also in the Philippines. And usually they have a lot of expansion of their service because they've been practicing it for decades ago already. So there are different expansion of clinical pharmacist services that they have. They have ward pharmacy, they have medication therapy adherence clinic, basically in the hospital setting, drug surveillance, medication, home medication review, harm reduction program, and also quality initiatives. So let's move on one by one. Now, the part of the medical team is in assisting pharmacotherapy decision making, especially in the ward pharmacy. What are they actually doing there? They usually assess patient. So you need to have competency in physical assessment. They do also rounds. They also do pharmaceutical care plan based on their interventions, bedside counseling, adherence counseling, identify also drug-related problems. So you can see here that they have patient assessment, no? Assessment in terms of their medication history, the disease that they have, the knowledge of the medications, adherence program. No, this is already compiled in one report, and also the documentations that they have in terms of the progress note, lab results, drug monitoring, the interventions are already there, and what are the issues then that was mentioned in terms of drug-related problems. And also there are forms on clinical pharmacy, referral form also with other healthcare provider, and also other hospitals. No? And these are the some example of the picture. You can see that the clinical pharmacists are doing medication history taking. So they are really involved in terms of talking directly with patient, and they also been involved in medical rounds, surgical rounds, with other healthcare provider. So they become a team. So when we say a team, it's not a solo flight of a clinical pharmacy, but it should be a collaborative approach between other healthcare providers. So we are not working as in silo as a clinical pharmacist, but as a whole, as a collaborative approach. So they also do bedside counseling. So it's part and parcel that you need to have this knowledge. When being asked by the patient, you need to have a good communication skills with the patient also. No? So, and also geriatric wards. So they also have with us geriatric, pediatric. So they also been part of the daily routines. Also in the medical wards in cardio, in pharmacotherapy rounds. So it's not only the rounds of the healthcare provider, but also pharmacists do also pharmacotherapy rounds. No? So usually, what's the human resource then of clinical pharmacists in Malaysia? So in a particular hospital only, they have almost 78.8%. They have almost 186 clinical pharmacists, full time that they have. In ICU, they have almost 47 clinical pharmacists alone. So it needs to have a lot of manpower, more work for clinical pharmacists, looking at drug-related problems, to avoid some errors. And of course, there's a lot of cases to be clerked. They have almost 258,000 of cases been reviewed, clerked, and been done in terms of medication history taking. No? And they have also reviewed if there are incomplete prescriptions. No? So these are the some of the works then in Malaysia for clinical pharmacists. They have also do medication therapy adherence clinic, wherein the main objective is to optimize drug therapy, improve medication adherence, reduce or prevent occurrence of adverse events. So what they usually do is that they become available if it is diabetes. So you talk about diabetes. So there is a pharmacist actually specialized on diabetic management, warfarin management, stroke management, psychiatry, rheumatology, hemophilia, psoriasis, and other services. So it becomes more specialized for clinical pharmacy. So you're not going to be in one round, you will round every patient or every uh, discipline. No? So it should be specialized, or else you're gonna be crazy with one specialization only. No? So these are the increasing trends of MTAC programs that they have in Malaysia. So you can see some pictures that they really advance the clinical pharmacist talking with the patient. No? So there are a lot of programs that can be done for ambulatory care services, especially for diabetic, especially in the country, still in the top 10 morbidity and mortality in the country. And another thing is home medication reviews, not only in the hospital setting, but they go beyond in the hospitals. They go also to the community setting, wherein they go also to stroke patient, to geriatric patient, and psychiatric patients. So you can see in the picture that they discuss their drug-related problems, their medication in their home. So that's one of the services that we can provide as clinical pharmacists then on proper storage of and disposal of medication, counseling to because some of them they cannot actually go to the hospital or it will aggravate their condition if they will go to the hospital. So they rather be at home. So as a clinical pharmacist, you can actually go at home and expand your services also. No? And another thing is there's a growing trend of home medication review in Malaysia. And another thing is harm reduction program for methadone. Methadone is one for those drug dependent patients and they have this methadone dispensing using a dots approach, the directly observed therapy for certain patients. So it's actually here the dots TB dots are actually mandated for nursing program to conduct it, but in Malaysia it's actually pharmacists who's doing it. So I think we need to a little bit change with this paradigm to be involved with this DOTS program, TB program, or methadone program for drug addicts in the Philippine setting. No? So drug surveillance, there are some drugs that need to be under surveillance. So we have antiretrovirals, immunizations. We have also antibiotics. We have surgical prophylaxis, adult audit. So it has a lot of what we call as drugs that needs to be addressed because this mostly of these drugs have a lot of adverse reactions that happen. No? So we need to monitor with this. Another thing for pharmacists in expansion is that is very essential for us is a quality initiative. How can we assure that our clinical pharmacy program are actually quality? There are no published with that in the Philippine setting. That we have a very lacking literatures that we have in the Philippine settings. And one thing that I learned when I do the book on the pharmacy practice in the Philippines is that the initiative of research and development is quite very low in the Philippine setting. So clinical pharmacists in Malaysia are actually involving themselves. No? So they have this national clinical pharmacy R&D conference yearly to present their work in terms of clinical pharmacy programs. So I hope and I pray that our clinical pharmacy program will also be very involved in terms of research because if without research then we cannot actually say that there will be evidences, no? Evidences that we have in our practice. Is it in quality? Is it effective, our intervention then? Are we significant then as a clinical pharmacist in the community or not? And so it should be backed up with research component then. Now, I'm going to leave with you with these parting words according to Henry R. Manetz. It mentioned here that it is really time for us to change. And as part of our objective and what is to be improved, I'm going to summarize it into what he actually mentioned here. He mentioned, according to Henry Manetz, that redefining care models for pharmacists will not happen if we continue to simply do more of what we have been doing and deploying our scarce resources in same way, repeated and repeated. Huh? We need a revolution of thinking in a pharmacy practice that's put us at the forefront of the patient care. So in this case, we need to revolutionize, change our daily practice. If we are more technical then in terms of our practice, then we need to involve in terms of collaboration with our patient, collaboration with our healthcare in terms of for the betterment of our patient. And that is the impact then that we can give to our clients, to our patients. Remember, clinical pharmacy is not only in the hospital setting, it can also be in the community setting. Clinical pharmacy is a way of life that we have. So it's not actually the a discipline only as a clinical pharmacist, but it's a way of life. a way of life of talking with our patient, talking about drug-related problems, no? Talking about the condition of our patient, and how can we have this intervention, the pharmaceutical care issues, no? That we need to have this intervention for our client. I think that will be all. So I'm Dr. Erwin Martinez Falier, a fellow a fellow and a professor of Bournemouth University, United Kingdom, and a fellow of the Royal Pharmacists in Singapore. Thank you very much.